Hey guys, welcome back to Jabstudiesmetfun for Anesthesia Part 3. In this topic today, for this video guys, I'm going to talk about at least 50 to 60 PYQs. So make sure you're well thorough with this topic, and if you have any other doubts, feel free to DM me. So let's start guys. As we already talked about in the previous video, monitoring of different systems. We talked about a few things about respiratory system. Let's talk about something which is, for example, ABG. Now ABG we're going to discuss in detail in the medicine videos, but for now just know that what ABG gives us. It tells us about the oxygenation in the blood, pH, carbon dioxide and bicarbonate. An important feature over here is that when you get to know about something which is known as central venous oxygen saturation or mixed venous oxygen saturation. Why this is important is because it is the best indicator of cardiac output, i.e. tissue oxygenation. How much oxygen has been taken by the tissue and what is left in the blood when it reaches the heart. Okay, remember the normal value, the normal values which are there. O2 is going to be 40 because most of them is taken by the tissue. Carbon dioxide 46, and if they'll ask you what is the average value of the mixed venous oxygen saturation, 60 to 80%. Okay. Next, if you talk about monitoring in the renal system, how you check it by using the urine output. What is the normal adequate urine output? You need to know it is between 0.5 to 1 ml per kilogram per hour. You also need to know that urine output is also known as the poor man's cardiac output monitor, because if the heart will not pump, there will be no filtration of blood and there won't be any urine. Okay. Next guys, let's talk about neuromuscular monitoring. Why is this important? Neuromuscular monitoring. Basically, it is to assess whether anesthesia and the plane of anesthesia has been reached or not. First, they're going to ask you is what is the most common nerve used? The most common nerve is going to be ulnar nerve. Why? Because it is easy that way. Okay. And what is the most common muscle which is supplying the ulnar nerve we are going to test? Over here, that is going to be your adductor pollicis muscle. Now the basic logic over here, why are we doing the neuromuscular monitoring is to check whether there is adequate relaxation of the main muscles, example the diaphragm, so that we can understand that okay, there has been proper relaxation and we can further do. Now what happens is whenever we are giving any anesthesia or any regional block per se, what happens is basically neuromuscular block, usually the smaller muscles are the one which are getting affected first, means they get anesthetized first and then the larger muscles. But there is an exception. Because you see the diaphragm has a vast nerve supply, it gets affected first, which means it is the one which gets relaxed first, then the small muscles. And the reversal is going to be opposite. In reversal, the large muscles are going to be activated first and then the small muscles. So what I just told is when you're giving the neuromuscular block, the first one to get is usually small muscles, but because the diaphragm has a large nerve supply, it is the one which is going to get paralyzed first. And when you resolve it, diaphragm again is the first one to get activated first, because over here during the activation, during the resolution of the anesthesia, large muscles get anesthetized, de-anesthetized first, then the small muscles. Okay. If I talk to you about how do you check this neuromuscular blockage and the testing which will be there, you have 4 tests. One is going to be a single twitch stimulation, one is going to be train of force stimulation, then you have tetanic stimulation and double burst stimulation. Let's talk about them in brief. Single twitch stimulation is you are going to give an electric impulse and check whether the muscle is going to be contracting or relaxing. Okay, this is the simple thing. It is just going to test whether the muscle is going to contract or relax. It will not help you. It will not help you to differentiate between a depolarizing muscular relaxant or a non-depolarizing muscular relaxant. You cannot differentiate with the help of single twitch stimulation. So for that, we have a very important thing which is a multiple times PYQ, that is going to be train of force stimulation. Now what is train of force stimulation is you're going to give 4 supramaximal stimulus at how much time gap? 0.5 seconds, and then we are going to calculate the ratio between the first stimulus and the fourth stimulus. So over here you can see this is example of the train of force. Okay, the train of force, which is usually 2 hertz. We are going to check whether the difference between non-depolarizing and depolarizing. Remember, in single twitch you could not differentiate, but in this train of force you can. How you can is, if you see this graph of the non-depolarizing block, you will notice that the difference in amplitude versus the first one and the fourth one is in the decreasing trend. This is known as fade, and fade is only seen in non-depolarizing block. On the other hand, if you're giving any depolarizing muscular relaxant, example succinylcholine, choline, you will notice that there is going to be a constancy. It is going to reduce overall, but all of them reduce together. But a fade is seen where in non-depolarizing block. Remember guys, whenever your train of 4 has a ratio of more than 0.9, that means it is safe for extubation. Extubation, you can do it, okay? You can do extubation. That is train of 4. Technic stimulation, as the word technic stimulation states, technic stimulation is something which is going to have a sudden and a large frequency, and then this is kind of painful. So you'll have a high frequency sound and it is going to be painful. Double burst is a similar test like technic stimulation, but it is less painful. That is all what you need to know with respect to neuromuscular blocking. Important is train of 4. Remember, fade is seen in non-depolarizing, constancy is seen in depolarizing, ratio of more than 0.9 is good for extubation. Next guys, let's talk about temperature monitoring. Now whenever a patient is under anesthesia, usually the patient is going to suffer from hypothermia. That is common. So what are the side effects of hypothermia? You can notice that there will be ventricular irritability at around 28 degrees Celsius. Respiratory system, you will see because of increase in shivering, there will be oxygen consumption also will be more because the muscles are more activated. The blood becomes more viscous, due to which the patient can suffer from metabolic acidosis. What are the clinical uses of hypothermia? We have already discussed this in case of management of raised ICT as well. But over here also you can use, as you see, the oxygen consumption and the BMR is reduced with each degree fall in temperature by around 10%. In brain production at the time of CPR, and along with that, you can help also to reduce the chances of tissue ischemia during cardiac surgery. So there are pros as well as cons with respect to temperature. If you see conditions like hyperthermia, where do you see hyperthermia? Already we discussed a condition like malignant hyperthermia, in which the defect was in ranolin receptors. Conditions like sepsis, where you have warm sepsis, malignant hyperthermia. Now how do you check the temperature? Temperature ideally must be checked by a core temperature than surface temperature. So come, let's talk about where do you check the core temperatures. Whenever you're having any CNS surgery, you are going to check the nasopharynx and the middle ear, which is tympanic membrane. So for neurosurgeries or any CNS surgery, you're going to check the nasopharynx and the tympanic membrane. Whenever you're having any cardiac related surgery, for example, cardiac the CABG, which will be the right. So in this condition also, you're going to check pulmonary capillary temperature. And remember guys, pulmonary capillary temperature is the most accurate. Okay, it is going to be the most accurate. If they'll ask you which temperature, pulmonary capillary temperature is going to be the most accurate core temperature. The most commonly checked is going to be mid-esophageal temperature. Okay. And this is usually done in case of GI surgeries whenever you're having any GI related complications. Rectal temperature, on the other hand, is usually done in case of emergencies like trauma because it is easy access. But remember, it is not a proper core temperature, rather it is intermittent. It is between surface temperature as well as it is between the core temperature. Okay, you don't rely on axillary or oral temperature for core body temperature. I hope this is clear. Next guys, let's talk about airway management. Now what is the purpose of airway management? So that we can get a good proper flow of oxygen into the lungs, and simultaneously we can remove carbon dioxide to avoid metabolic acidosis. What do we need to know before doing the airway management? You need to know the functional anatomy. You need to know how do you do the exam. You also need to know how do you use the equipments at time of danger, and also you have to get used to the practice. Okay. Talking about the functional anatomy, there is a lot of things covered over here. Just know the basic, it's actually most of anatomy, so we'll cover up at that time. So you just get a thorough read through this once. Remember, where does the nose lead to? The nose leads to a nasopharynx. Okay, and from nasopharynx it goes to the anterior trachea. Remember, trachea is in the anterior part and esophagus is the posterior part. Okay, and whenever you see the nose, always check for any nasal septal deviation is there or not. Through the nasopharynx you will have adenoids. So that is why usually adenoid hypertrophy is seen where? Adenoids are usually seen in children and not in adult. If you have any suspicion of an adenoid type mass in an adult, what is the condition? You have to suspect for nasopharyngeal carcinoma and you have to go for biopsy. Okay, so we brought ENT also in our integration. Next guys, if you see what is with respect to any mouth obstruction, what is the most common cause of obstruction? Whenever the tongue, it falls back. So that is why that is the most common cause. It goes and blocks the oropharynx. So what you have to do is you have to push the patient to the left lateral decubitus position and do a jaw thrust. That is the management. If you're outside, if you don't have any medical equipment, always to put the patient in the left lateral decubitus position and a jaw thrust so that you prevent chances of aspiration as well. Okay. Remember guys, how do you open your mouth? Using the temporomandibular joint. It has two movements. One is going to be rotation, the first one, and then it is going to be sliding. Okay. If you see what is pharynx, pharynx is going to be a muscular tube, And what type of obstruction can pharynx cause? It is going to cause a dynamic obstruction. If you want to know about the larynx is made up of three type of cartilage, 3 paired and 3 unpaired. What are the 3 paired cartilage? Comment below. And what are the 3 unpaired cartilage? Very good, comment below. Okay. Again, if you don't know it, make sure that you write this down in front of the your study room, and also along where make sure you comment below also, so that you will not forget again. Another very good important PYQ with respect to anatomy is all the laryngeal muscles are supplied by the recurrent laryngeal nerve except for one muscle. Okay, which is that muscle? Again, comment below, because it is supplied by the external branch of the superior laryngeal nerve. Okay, another PYQ over here is the sensory supply above is supplied by the internal branch of the laryngeal nerve, and below is supplied by the recurrent laryngeal nerve. That much you should know. This is all, at least in this slide only itself, you're having around 5 to 10 PYQs. Okay, so make sure you comment below the answers. Next, guys, let's talk about predictors of difficult intubation. So as first thing you see a patient and you are planning to intubate, with just visual, without any checking, what are the things which you see in this patient that you will see, like, okay, there might be some difficulty in intubation and I have to prepare well. So you can remember this with a mnemonic of obese P, where obese O is going to be, obese, which will be the O, obese, which will be is again obese. Okay. B stands for bearded, if someone has a beard. E is old patients, which is elderly. S will be there someone who snores. Okay, and E is for edentulous, which means no teeth. Okay, and P over here stands for pregnancy. So you can remember this word by obese pregnant lady. Okay, so these are all the conditions in which you might have a difficult intubation. Obese, P. Okay, obesity, bearded, if you will see elderly, edentulous, snoring, and pregnancy. Okay. Next, guys, let's talk about more details of difficult intubation, and the very important thing which comes almost in all FMG, NEET, PG, INI questions is Malampatti scoring. So if you talk about Malampatti scoring, which will be there, remember guys, Dr. Malampatti was the one who gave 3 grades, grade 1, grade 2 and grade 3. If they'll ask you about the other thing is, remember grade 4 was given by Samson and Young. Grade 4 was given by Samson and Young, while grade 1, 2 and 3 was given by Malampatti. Now, what you have to remember in this is, I just given a lot of details over here, like fascial and stuff like that. But usually what they ask is over here what I'm going to talk about. First thing is the uvula. Class 1 is tip is visible. Okay. Class 2 is uvula tip not visible. Okay. Class 3 is half of uvula visible. And class 4 is when only the hard palate is seen. Okay, so remember this Malampatti scoring. Class 1 is when you see the entire uvula. Class 2 is when you cannot see the tip of the uvula. Class 3 is half of the uvula is seen. And class 4, when no uvula, only the hard palate is seen. That is your Malampatti scoring for assessment of difficult intubation. Okay. Next, you have to remember over here is mouth opening. How can you check the assessment of mouth opening is by the finger breath test. What you're going to ask the patient is to put 3 fingers in between the mouth, in between the incisors. Okay, if they're able to put 3 fingers, it is good to go. It won't be a difficult intubation. But in condition of people who are having tobacco chewing habits, they will have submucosal fibrosis, because of which even sometimes, if any time the value is less than 2 finger breath, that gives you an assessment that it is going to be a difficult intubation. Okay, then you'll have a thyromental distance. The normal distance of thyromental is going to be around 6.5. Anytime the value is going to be less than 6, it is going to be difficult intubation. Then it's going to be your sternomental distance. Sternomental distance normally is around 13. If the value is less than 12, it is going to be difficult intubation. Cervical spine mobility. You can check the cervical spine mobility by 2 ways. One, by checking the angle between the forehead over here when it's flexed and forehead when it is extended. If this angle is less than 80, it is going to be difficult intubation. Or if you talk about the cervical spine mobility, usually it is going to be around 15 to 30. But if the cervical spine mobility is less than 12, that is also going to be a sign of difficult intubation. Cervical spine mobility is restricted in conditions like ankylosing spondylitis. You have another test, which is your mandible protrusion test, in which you will ask the patient to protrude the lower jaw, and if they're able to do so, good enough. If they're not able to do so, again, sign of difficult intubation. Next, guys, let us talk about the how to intubate process. Remember, guys, there are multiple scoring systems, okay? But the most common one which we use is the Wilson score. If you talk about how do you intubate a patient, there is going to be a series of steps. Before intubation, always first what you have to do is something which is known as pre-oxygenation. What is pre-oxygenation is 3 minutes we are going to give 100% oxygen. Why are we giving this is because so that we can increase the apnea time to up to 10 minutes. I'm going to give 3 minutes 100% oxygenation so that I can increase the apnea time up to 10 minutes. If, for example, it is a very severe case of trauma and the surgeon is we don't have 3 minutes, then we are going to prefer the 8 vital breaths. If 8 vital capacity breaths are not possible, the minimum which you have to do is 4 vital capacity breaths. So what I said is, first you have to do 3 minutes 100% oxygen, then it's going to be 8 vital breaths, and then it's going to be 4 vital breaths. So please remember this with respect to pre-oxygenation. After we're done with this, we're going to do with the inducing agent. We'll talk about that in the next module. Okay. The next thing what we are going to give is we're going to give muscle relaxants. Now, in case of emergency, the muscular relaxant of choice, or in case of difficult intubation, is succinylcholine. If you are not giving succinylcholine, for example, if there is any contraindication, you're going to give rocuronium. Okay. After giving a muscular relaxant, before giving the laryngoscope, remember guys, whenever you start using the laryngoscope or you're going to give endotracheal intubation, these are most potent sympathetic stimulants. Because of this, it is going to increase adrenaline and noradrenaline and thereby increase the workload of the heart and the body overall. So we don't want that. What are we going to do is we're going to attenuate the response. And how do you attenuate the response? We are going to use drugs like lignocaine, nitroglycerin. You'll use opioids, which will be example like L-fentanyl or fentanyl. These are the ones which are going to attenuate this response. Okay. And after that, we're going to extubate. So I'll tell this one more time. First, what we are going to do, pre-oxygenation, 100% oxygen for 3 minutes, so that we are going to increase the apnea time up to 10 minutes. If there is severe condition, 8 vitals. If even more, even less time, 4 vital minimum. After that, we're going to give the inhalational agent. After that, muscular relaxant, either it is depolarizing or non-depolarizing. After that, you have to give to attenuate the response, which can be exaggerated by the laryngoscope and the endotracheal intubation. Drugs like preservative-free lignocaine, nitroglycerin, and short-acting opioids can be given. Okay, and then you can extubate the patient after your procedure is done. Okay, so this is the whole cycle of intubation. Next, guys, let us talk about how are the processes and what are the facts you have to remember with respect to intubation. Normally, guys, intubation, how it is done with respect to how is the position. The normal position is going to be the lower cervical spine is going to be flexed and the atlanto-occipital joint is going to be extended. Remember, cervical spine, it's written here, lower cervical spine is going to be flexed and there will be extension at the atlanto-occipital joint. Okay, if they'll ask you what is going to be the position of the head, it is going to be like this. Remember how you drink beer like this? So it will be like drinking pint beer, or it will be like sniffing position. Okay, so remember like this, sniffing position or drinking pint beer. Next, guys, whenever you're having suspected spine injury, always be careful. Don't flex too much, otherwise it can cause more further plexus injury. So then you will have a criteria which will be there, which is going to be mid inline stabilization, which will be there. Okay, make sure you get that done. Now, in case of emergency, as I already told you, the inhalation, the muscular relaxant of choice is going to be succinylcholine. But if succinylcholine is contraindicated, you're going to give rocuronium. This thing is known as rapid sequence intubation. I'll talk about the difference between a normal intubation and rapid sequence intubation later on. But in this rapid sequence intubation, what you do is, because you don't have too much time and you want to prevent the risk of aspiration, you're going to apply a cricoid pressure, which is known as Selesic maneuver, so that you prevent aspiration through the esophagus. Okay. In case of awake intubation, we have to give nerve blocks. And in case whenever you have an obese patient, the position which we are going to keep the patient for intubation is going to be a ramp position, and ramp is nothing but a reverse Trendelenburg position. Okay, a reverse Trendelenburg position. If you talk about like this, nasal intubation. Nasal intubation, when do you do it? Is usually in case of an oral surgery. But remember the contraindications. The contraindications are, first of all, if you are in children, you don't do it because in children you have hypertrophied adenoids. First thing. If you have a fracture of the base of the skull, that time also you're contraindicating nasal intubation. And third, very important thing is coagulopathies, which means bleeding diastasis. Okay, what are the 3 contraindications of nasal intubation, guys? If it's a child, hypertrophied adenoid, if there is coagulopathies, and third, if there's a fracture of the base of the skull. Okay. Next, guys, what is the difference between rapid sequence intubation and a modified rapid sequence intubation? rapid sequence intubation, the very important thing is we are not going to pre-oxygenate this patient to prevent the risk of aspiration. Okay, so that is why you're not going to give any mask ventilation. On the other hand, in modified rapid sequence intubation, there's going to be gentle ventilation. The inducing agent of choice in rapid sequence ventilation is going to be thiopentin sodium, and in modified one, it is going to be propofol. The muscular relaxant in case of RSI is going to be succinylcholine. In modified RSI, you're going to be succinylcholine or rocurinum. In both of these methods, we are going to be applying the Selesic maneuver, which is pressure to the cricoid cartilage so that to prevent the risk of aspiration. Remember, only to release this pressure once the cuff is inflated, once the ET cuff is inflated. Okay. Next, guys, let's talk about the airway equipments. The first thing which is there, a very important PYQ, this is a airway face mask. Now, what is the uses of airway face mask? Obviously for oxygenation. How are you going to do it? You're going to do it, how you're going to hold it, it's going to be a C and E maneuver. C will be holding the mask, and E which will be there will be up over here into mandible, the bony surface. Remember not to hold the soft tissue, because if you're going to hold the soft tissue or fat, it is going to apply pressure and this fat will go and obstruct further the airway. So remember, when you're holding it with using the E which will be here, make sure you're using it at the bony prominence. Okay, and the maneuver which you use is going to be triple maneuver, which is going to be head tilt, chin lift and jaw thrust. Okay, so head tilt, chin lift and jaw thrust. Remember this maneuver. What are the side effects which are like, the cons in this condition is, because if you will apply too much pressure, there can be, the air can go to the gastric pathway via the esophagus, causing gastric distension, and thereby it can also lead to aspiration. Second condition is that because this, if you are not properly putting the mask, it can cause damage to the cornea as well. Okay. Next, we are going to talk about Goodell's airway. Now, usually what happens is a side effect in case of if a person falls in seizures or unconscious is that there will be obstruction because of the tongue. Goodell's airway is something which prevents the tongue to fall back. So if it's preventing it, we're preventing something which is their airway obstruction. The disadvantage on the other hand is G for Goodell's, and Goodell's causes gag reflex. Okay, G for Goodell's and Goodell's causes gag reflex. Make sure you know this image because they usually ask it. Okay, how do you check the size of a Goodell's airway? From the angle of the mandible up to the tragus, or to the angle of the mouth to the tragus, or angle of the mouth to the mandible. That is the way. Now, to prevent this gag reflex, we have another airway which is your nasopharyngeal airway. Again, nasopharyngeal airway, same contraindication like nasal intubation. Adenoids, no. In case of base of skull fracture, no. In case of coagulation, no. The advantage of nasopharyngeal airways is there is no gag reflex. And how do you use it? From the lateral part of the nostril to the tip of the tragus. That is the length you are going to decide. Next, guys, let's talk about laryngoscope. Now, there are two types of laryngoscope, guys. One for adults and one for children. Remember, Macintosh is also known as curved. How you remember this? Macintosh, M-A-C. There is a C in Macintosh, and curved. C is for curved. On the other hand, the one which is in children is known as Miller or linear. So how you remember this? M-I-L. Miller has L in this, and L is like a straight, right? It's like a straight line. So it will be like a straight blade. Okay, so Miller straight line, and Macintosh has a C, so it will be a curved blade. Remember, Macintosh or curved blade is used in adults, while as Miller or straight blade is used in pediatric cases. How do you hold the laryngoscope? Remember this sequence they usually ask. Whenever you're holding the laryngoscope, you're going to hold it by your left hand. Then you're going to go with the right angle of the mouth. You're going to move the tongue, and you're going to go forward up to the base of the tongue. Okay, remember, in case of adults, you don't include the epiglottis. And whenever you're moving your laryngoscope, don't use the wrist. You have to use your deltoid and your triceps muscles, because if you use the wrist, there is chances of damaging the teeth. I repeat, you're going to hold the laryngoscope with your left hand, going to go to the right side, move the tongue, and go up to the base of the tongue. Once you see over here, don't rotate the wrist. You have to use your deltoid and the triceps muscle to move. Okay. On the other hand, in children, remember, in children, Miller or straight, the epiglottis is involved. On the other hand, in case of Macintosh, epiglottis is not involved. Over here in Miller one, you directly go straight, which means in the middle of the oral cavity you do it. And remember, you include the epiglottis. So over here, as you see, this is a straight one. Straight one, remember, it is going to be Miller. While as a curved one, curved has C, so it is going to be Macintosh. Okay. Next, guys, let's talk about further types of intratracheal ET tubes. Remember, guys, whenever you talk about ET tubes in adults, it is going to be cuffed. Now, the reason of cuffed over there is not to keep it in place. The reason of cuff is to prevent aspiration. Uncuffed ones are usually seen in children. Now there is a reason why you use uncuffed, or right now what they prefer after COVID is to use micro-cuffed EDD in children. The reason why is because the subglottic region in case of children is the narrowest part. So it already does not require the risk of a cuff because it can help itself for preventing aspiration. But in adults, the narrowest part in case of the supraglottis, glottis and infraglottis is going to be the glottis region. So for that we need a cuff. Talking about the size of the endotracheal tube, remember in adults usually you can put 8, 8.5 or 9. In females you can do 7, 7.5 or 8. A very important PYQ is in preterms you can put a size of 2.5. In term child you can put 3. And up to 1 year of child you can put 3.5. Okay, if you talk about how much the size and the circumference of the EDD should be there, remember if a child is less than 6 years, you're going to divide the age by 3 plus 3.75. If the child's age is more than 6 years, you're going to divide age by 4 plus 4.5. Okay, what are the signs of correct endotracheal tube placement? First is, if you just see, chest lift is going to be bilateral. When you see the ET tube, there's going to be moisture around it. Okay, there will be mist. Then when you do auscultation, you'll have bilateral air entry. Okay, the surest sign if they'll ask you is going to be capnography. Remember we were talking about ETCO2, so that is your capnography. If they'll ask you what is the gold standard, the gold standard is going to be fibro-optic bronchoscopy. At last, whenever the patient is admitted in the ICU, just to check if the ET is placed, you can do a X-ray. So remember this: chest lift, bilateral sounds which will be there in auscultation. Gold standard is going to be fibro-optic. Surest sign is going to be capnography. Okay. Next guys, if you will see, there are other modifications of your ED tube. One is going to be a flexible spiral wound type. This armored tube is also known as flexible metallic endotracheal tube. The use of this is in case of prone surgeries. Okay, and why? Because it helps in prevention of kinking. Okay, because in prone positions there will be chances of kinking of the ET tube, so that is why you can use a wire based one. And over here you can see there is a wire within. Over here you can see there is a wire within this tube, and this is your flexible metallic endotracheal tube. Okay, the next tube over here which you see is there is your over here your north pole and south pole RAE tube, and this RAE tube is used for surgeries like left lip or palate. Okay, and over here this tube is your double lumen. You can see this is a double lumen endotracheal tube, and this double lumen endotracheal tube is used for selective ventilation in case of lung surgeries, like if a patient has pneumectomy or lobectomy, to ventilate the other lung and not to ventilate the other one, you can use the double lumen tube. Okay, one will be placed in the trachea and the other one will be placed in the bronchus. Okay, so this is all about your RAE tube. Double lumen microlaryngeal tube we already discussed, that is used in children. Okay, the other further gadgets which you need to know PYQ based on images, one will be your air trachea over here. Now usually because we were not doing laryngoscopes in case of COVID time because aerosol production was more, so that is why now they used to use video laryngoscope so that there was less aerosol production. Another true scope was there, just remember the images, they might ask like this. And a similar type of pattern of fibro-optic bronchoscope was your ambuscope. Okay, these were all the other instruments which are used in case of endotracheal intubation. After endotracheal intubation guys, let's talk about another airway device which is your supraglottic airways. Supraglottic airways, as the word says, these are positioned above the glottis. Okay, so your supraglottic airway, the main thing which is your LMA, which is your laryngeal mask airway. What is the advantage of laryngeal mask airway? The advantage of laryngeal mask airway is it is easy to place. Now you see endotracheal intubation is kind of complicated. You have to see if there is suction, there is too much secretion, you have to suction, and then it is based on experience. But LMA is kind of easier because it is superficial work. But along with ease, there comes a complication, that is it does not prevent aspiration. Okay, so now we need to know what are the different type of LMAs. Obviously the new ones are known as second generation ones, and the second generation ones are obviously better than the prior one. Over here you guys, you can see the difference in this is that it has two tubes, one here, one here. The other one is over here is to remove the secretions. So this is known as ProSeal LMA. Okay, it has another balloon tube as well, but this is another for secretion, they have a tube. So that is why this is known as ProSeal LMA, and this is the one which is a betterly preferred LMA. Another one over here, classic one, this is here, which is made of polyvinyl chloride. This is your LMA Supreme. Okay, and the thing in LMA Supreme is that you have another gastric port into it. Okay, you have the balloon as well, and it is made up of polyvinyl chloride, and it is a high sealing pressure type LMA. Okay, high filling pressure type LMA. Whenever you see multiple stuff like this is going to be a fast track LMA. Remember, in a fast track LMA, you don't have any gastric port. Gastric port is absent. Okay, a new one which is there and which they expect the questions can come is, this is a second generation iGel LMA. Now, why this is advantages is it has a gastric port. Along with that, this part, the green part over here, it is the one which goes in situations in your pharynx, and this can remodel and shape based on the person to person's shape of pharynx. So that is why this is important. Remember, this is a iGel LMA, and remember, it does not have a the pilot balloon plot. This pilot balloon plot in which you use it over here, these are the pilot balloon plots. Okay. Last one, just remember over here, it has a like a dip over here, that is your SILPA. You don't need to remember the full name. So these questions can't come with respect to any history based thing. Mostly they're going to come with identification purpose. So make sure you know these images. Okay, one more time. Normal one, that is your LMA. If you have another secretion tube, that is your ProSeal LMA. You see this white type one with the tube and with the gastric port, that is going to be your LMA Supreme. Multiple things around and around, that is going to be a fast track. Green bottom, that is going to be iGel, and a gap in the between, that is going to be a SILPA. Okay. So just a few other things which are used in case of intubation. One is your iGel. You can use this another way with the help of optics, that is going to be your lighted optical stellate. Then over here, this is a stylet, a smaller one, and the larger one at the time of intubation is going to be introducer bogey. Okay. So for the last topic over here is going to be difficult airway management. How do you manage it? Now, basically, this plan is consisted of 4 plans, which is A, B, C, D. I'll tell you how the plan is. First is when you see there is an indication of intubation. For example, remember, whenever a patient's Glasgow Coma scale is less than 8, you have to intubate. Okay, remember the rhyme, less than 8, you have to intubate. Okay, so there are 4 plans, plan A, B, C, and D. Plan A means you're going to try to do the, with the help of laryngoscope, you're trying to do endotracheal intubation. If this fails, now come plan B. Plan B is going to be LMA trial, laryngeal mask airway. So if even the laryngeal mask airway fails, then you will do normal bag and mask. And during this bag and mask thing, you're going to try again. If you're going to check out the possibilities, you're going to call the anesthesiologist and or the ENT doctor to do a tracheostomy. But still, if the patient's saturation is not getting improved even with bag and mask, the next step, which is plan D, is going to be cricothyroidectomy. Remember, cricothyroidectomy, guys, it is only a temporary way. Okay, it is only a temporary way. It is not permanent. Permanent is going to be done by an ENT doctor. That is going to be your tracheostomy. Okay, it is going to be a tracheostomy. Okay, I'll repeat, this is a guidelines which will be for difficult airway management, DAS. So first one is plan A is going to be with the help of laryngoscope start a endotracheal intubation. Failed, do LMA, laryngeal mask airway. Failed, then you have to do bag and mask ventilation. If even that is not working, their saturation is still not going, you have to do a cricothyroidectomy. Okay, so this is all with respect to the types, with this, how do you do and what are the devices used in case of intubation and other things. Now let's just bring another, I just want you guys to integrate. So this is something with related to surgery. There are 3 stage classifying criteria for this diagnosis. You have Apache 2, you have Gleason score, and you have Ranson scoring also. This is prognosis factor used in which condition in surgery? Comment below. Okay, so that we can integrate and study together. So guys, that is all for this video. I hope you enjoyed this video. I hope you understood. If there is anything which you have doubts, feel free to text me on my Telegram page, and make sure you are very well thorough, because amongst the 3 videos which I have done so far, in this I feel there is maximum amount of PYQs, image based questions, related questions, and much more. Thank you, and see you guys in the next video. Take care.